Welcome to Cardiology Grand Rounds Conference from Houston Methodist, DeBakey Heart and Vascular Center. My name is Dr. Alpesh Shah, and I'm an interventional cardiologist. Today, we are privileged to host Dr. William Lombardi, who will share his knowledge on improving patient care in PCI patients, especially with CTO. I'd like to welcome our viewers to participate and ask questions to Dr. Lombardi. This can be done in two ways. One is to go to pollev.com and enter DeBakey, and second by texting DeBakey to 37607 and typing your message. Dr. Bill Lombardi is a world-renowned expert in complex coronary disease therapies, performing over 500 interventions a year, including 250 CTOs. He continues to develop novel chronic total occlusion techniques and technologies, including the inception of a hybrid algorithm that facilitates successful, reproducible outcomes in CTO and complex lesion PCI. He has been involved with over 20 new technologies to improve PCI, including guide wires, microcatheters, specialty balloons, and novel approaches to reduce radiation and orthopedic injuries to operators. Dr. Lombardi completed his MD at Tulane Medical School and went on to the University of Utah, Salt Lake City for his internal medicine residency and fellowship in cardiology, heart failure, cardiac transplant, and interventional cardiology. He is board certified in interventional cardiology and cardiovascular disease by the American Board of Internal Medicine. He continues to innovate at the University of Washington Medical Center as clinical professor and director of the Complex Coronary Disease Therapy Program. Dr. Lombardi's focus remains improving outcomes through numerous collaborations with his colleagues, industry, and teaching the next generation of CTO operators. On his free time, Dr. Lombardi enjoys spending time with his family on their boat, Lioness, fishing, and exploring the outdoors.
Thank you, Dr. Shah. Thank you for having me.
So your name is both the Lioness, and in our field of CTO PCI operators, you are our lion. So we are really excited to have you here. Thank you so much for joining us from the West Coast, and we are very eager to hear from you if you can share your thoughts on advancing our field and improving patient care.
Thank you, Dr. Shah. I appreciate that. And yeah, if you knew my wife, you'd know why the boat's named Lioness. So I may be a lion outside the house, but not in it. So what I want to talk about today is actually a really challenging topic for most of the people who are going to watch. And a lot of it is about, the theme would be minimum competencies and how care variability related to competency in regards to technique affects all of the trial data that we hold dear and affects the way that we provide care to patients. And really, this is a patient-centric talk, not a doctor or hospital or society talk, which is what really most of healthcare is about. These are my disclosures, as you saw earlier. I try to be equally conflicted with everyone. The other thing I want to just say is this is not a talk about PCI versus cabbage, because I think it's not a very important talk. I think that the history of our profession is that cabbage is better. And instead of really complaining and running the same trials over and over again that demonstrate the same failure mode, I think we just saw that with FAME3, is why is PCI not as good as cabbage? Okay. And the second is, what do you do for people who cabbage isn't an option, right? Because we don't send them to cabbage because of indications. We send them to cabbage because we can't treat the coronaries. And that leaves you with, are medications actually better than revasc? And that's either surgical or percutaneous. And I think, again, you have to look at the way the data is developed. Is it really true? So I want to start to help set the understanding of care variability with a story. So everyone who's on the call, I want you to think for a minute, if you fell down right now with crushing substernal chest pain and couldn't talk and had to call 911 because you're having a STEMI, do you know which hospital the ambulance will take you? The second question is, do you know who the worst interventionalist on call is at that hospital? And are they adequate? Would you feel comfortable with them doing your PCI? And the reason I bring this up is a good friend of mine who's a well-known interventionalist in the Midwest had an anterior wall STEMI, went to the hospital that he works at. The person on call doesn't know how to do radial access. Remember, only about 65% of cases in the U.S. are still done femorally. Sorry. So we know that radial and STEMI is one of the places where it actually it saves lives. But he can't have that because the operator doesn't know how. The other piece, the operator doesn't know how to interpret IVUS. And as we'll show later, image-based stenting is a huge benefit to both short and long-term outcomes. So now this person basically has to take no conscious sedation, have the doctor get femoral access, has to read their own IVUS so that they can get an appropriately sized stent. To me, that's the story of minimum competency. And I can tell you personally that the two hospitals in theory that I'm supposed to go to, I know all 9 of the interventionalists at the 2 hospitals. I don't want them to come near me. So that's a real problem in our profession, is because whatever's good enough for me should be what's good enough for our patients. Not, well, the patient should get this, but I should get something different. And I think that's a part of the story. So another story that brings us up is, here's a 54-year-old gentleman. At 44, he got a bare metal stent of his OM. It occluded. So at 45, he got a bypass surgery, got a Lima to the LAD, vein graft to the OM, and a vein graft to the PDA. 6 years after that, amazingly enough, both the vein grafts failed. Okay. So he was sent, because his operator said there was nothing that could be done percutaneously, sent him for a redo cabbage at 51 to get 2 veins. At a year, both those veins were out. So he's got 50% of his heart's ischemic. He's got normal V function. He's got a CTO of the CIRC, a CTO of the PDA. And his board certified interventional cardiologist tells him nothing can be done for him. Okay. So think about that. Is there really nothing that can be done? All right. So now he's got class 3 angina. He's on 3 drugs with a high-risk nuke with inferior and lateral wall ischemia. Okay. He's told there's no options for treatment. So the question for all of you, are there really no options? And how many of you right now are, well, I need to see the angiogram to see if there's an option. Well, why do you need to see the angiogram? We know that the PDA needs to be treated. We know that the CIRC needs to be treated. The reason you look at the angiogram is because you want to see if you can treat it. It really should be the other way around. The angiogram should just tell you, this is how I'm going to treat it, which should be either with surgery. And I don't think anybody's going to go for a 3rd surgery, but maybe. But just to satisfy you, here's his angiogram. See the occluded stent, big collateral to the OM, big PDA. You can see where the old graft insertion is in the PDA. So what would you do at the Texas Heart Institute? Right? Because he's not going to be at the University of Washington. So this comes back to care variability. 3rd cabbage, he's already had vein grafts go down twice. Well, maybe we'll do a radial and a REMA this time on his 3rd bypass surgery. Hope and poke, maybe we can get at least the previous stented OM better. Should we put him on Renexa? Got approved because it can make you walk 42 seconds longer on a submax Bruce. That's important quality of life. Hey, you guys are big home of stem cell therapy. I started as a heart failure transplant doc. Stem cell therapy was 5 years out 20 years ago. Are we there yet? How about EECP? Maybe we'll just do, he's 51, he can't work, can't follow his kids, but, he can live with it. Or can his lesions be treated? And is the ability to treat his lesions a you thing, patient thing? So in this case, obviously, we went ahead, easily crossed the CIRC. His bare metal stent was markedly underdeployed. We put in a new drug-eluting stent. We then went retrograde to do his PDA. We used the Lima to help see, and you can see a collateral out in the distal vessel. This is not really all that important. Wired the septal to go retrograde, which at most CTO programs represents about 35% of the procedures you will do. And about 50% of the procedures you will do will be on people who've had previous bypass surgery. So we went retrograde, did bifurcation image-guided stenting. He had complete revascularization. He became asymptomatic. He went back to work. He's not had an issue since that time. So it could be treated. But the whole point of that discussion is every one of you on this call thought differently. There wasn't a standard of care. This is what we should do. And most of what you're thinking was driven by what you either technically can do yourself, 2, what you've seen your partners or your institution do, and 3, your interpretation of the data, which is affected by those outcomes. So one of the problems I have with our profession is the following. So think about the things that you take as the standard of care, right? Bypass surgery. Nobody's going to equivocate or give any of the surgeons at the Texas Heart Institute a single issue with doing a cabbage. We're putting a defibrillator in. We're doing PCI. What I trained with the guys who did beta blockers and heart failure. I actually was doing research in beta receptor physiology. TAVR, transcable access. How about CTOs? Lead extraction, VT ablation, AFib ablation. I want everyone to think about those are things that are pretty common practice, right? We accept that's the care. I also want you to realize is everyone who did that for the first time was lambasted by our profession. All of the people that were the leaders that brought it out were lambasted and crucified by the profession. Why are we so resistant to change? Why does our academic leadership step so hard on preventing people from evolving and getting better? And I think that's something we need to think about, which is, are we open to change or closed to change? Because I would say for the most part, we're closed. And I can sum that up in a simple thing is we use, well, I'm a conservative doctor. Now, conservative has these very nice connotations. Oh, you're thoughtful and you're doing the right thing. But really what conservative is you're out of date. Usually it's the older people who haven't kept up, who are resistant to change. Whereas we say people, well, I'm aggressive. Well, aggressive is just somebody who came out of training who's doing what they were trained. That's not aggressive, they're current. And why do we resist people who are current? Shouldn't the fellows coming out be the best, most up-to-date people? So shouldn't we be asking them, what did you learn? What should I know? How do I get better? Something to think about. Now, there's a lot of issues with trial design. I think the biggest is operator and selection bias. Most of the trials that have come out right now don't represent your clinical practice. And the reason they've had such slow enrollment is because nobody believes in the trial design, so they don't enroll any of the patients. So how relevant is a trial that excludes 90% of the people coming through? Okay. And the other is there's a lot of unconscious bias. You know, the aspiration technology is basically lost because the operators refused to randomize people who had the highest amount and highest burden of thrombus because they thought the benefit was there. Well, your trial failed because the people who would derive the most benefit, you didn't enroll in your study, so you unconsciously biased it to fail. And that happens in a lot of trials. And then the other is most of the trials that we run are run like medicine trials, right? I get a randomized double-blind placebo-controlled trial. The problem is if you're talking about therapies, then you have this problem about crossover. Well, how come when you cross over, that's not a failure of the medical arm? It's never considered a failure. But it infects your outcomes because it's really then becomes intention to treat. Well, but if 40% of the people got revasc who were supposed to get medical therapy, your power calculations are all wrong, your trial's useless, and it should never be published. That's why I don't carry a subscription to the New England Journal, because Courage was not a properly done trial. I don't care about the outcomes of it, but you can't have a trial with a 4% pre-specified crossover rate, have a 40% crossover rate, and then think that the data has any value, good or bad. And this comes up in Stitch, right? So if you look, the people who did the worst in Stitch were people who were randomized to get a cabbage. The surgeons refused to do a cabbage, and they got left on medical therapy. Okay, so is that a failure of cabbage? Because they got counted as a failure of cabbage. Well, really, revasc might have helped them. We just didn't do it. And that was 4% of the population. There was another 4% that was in the medical therapy arm that went on to get cabbage. And they actually did the best. So think about how that affected the outcome of the trial as an intention to treat. And that's why here, bypass surgery at 5 years is a win. But in the trial that was published, it took 10 years. And it's because we weren't comparing cabbage to medical therapy. We were comparing intention to treat to intention to treat. And we blurred the data such that we didn't actually test the real therapy, which was bypass surgery. Now, this also comes up in Syntax. And for those of you who haven't heard of it, Syntax 2 was a trial of PCI versus cabbage. Now, first of all, it was cherry picked. So more than half the patients went to a registry. 90% of those had bypass surgery. So when interventionalists see hard coronary disease, they run away because we're not very good. But even despite that, we did the randomized trial where both people looked at it and said, we can do this. What this trial or this slide shows is the following, which is if I do the trial here at these centers, PCI wins because the surgical MACE is high and the PCI MACE is low. If I do the trial over here, then surgery wins and PCI loses. What we got was sort of the murky data. But what I take away from this trial is this has nothing to do with stents versus bypass. This has to do with operators versus operators. So what you have to do, which is the hard thing to do, right, is are your surgeons better than your interventionalists? Are your interventionalists better than your surgeons? Are they roughly the same? How do you coach that? How do you equate that? How do you know whether that's actually real? And that's because it's a very different skill set to fix a type A lesion, right? Which is basically flying an airplane VFR. And I show this because my dad was a commercial airline pilot. And I can tell you the minimum competency to fly a commercial airline is a lot different than the minimum competency I had to fly a Cessna 172. And my father, who had 30,000 hours of flying time, got on a simulator and couldn't land a Navy jet onto an aircraft carrier despite 30,000 hours and a heck of a lot of competency, because this competency is even higher. So the question is, how competent are we to do this stuff? Okay? Because it's different skill sets, right? How about fellowship training? Our fellows right now have both done more than 25 atherectomy cases. Matter of fact, the last atherectomy case my fellow did, I sat in the control room and they did an unprotected left main rotablator case without me scrubbed. Now, imagine another institution where the fellow's done 200 PCIs. They haven't done a left main. They haven't done an atherectomy case. So when those two graduate, day one and come out, are they really the same? Did they get really the same training? Are they going to be really the same competent? That's a big deal. Because to the person on the table, that's a big deal. Now, we talk about public reporting, and all I'm going to show this is to show that public reporting harms populations. So what this basically shows, this was done by some guys up in the East Coast. What it shows is if you basically have an MI and you go to not New York and Massachusetts, you're actually more likely to get a PCI and you're more likely to live because your all-cause mortality is higher in reporting states. So what this says is if I do public reporting, what's going to happen is we're going to actually not treat the people who are at the most risk, which means at the most benefit to get fixed. So public reporting's as an unintended consequence, which is it forces people to not do what they do. And I know this because when I first started CTOs, for 5 years in a row, I was the number one worst interventional cardiologist in the state of Washington because failing a CTO was an adverse event. So was I really the worst doctor in the state? I don't know. You'd have to ask other people. But I think that's something you need to think about when we start talking about public reporting. And it also goes back to don't read the New York Times, don't read the abstract. You really need to delve into what is the data saying, because there's actually a lot of things going on that actually matter because it matters to people. Now, there's been a huge growth in PCI, right? There was 16.5% growth in PCI volumes when I just came out of training. And it was all about access to care, access to care. Remember, we have to have a STEMI center on every corner so patients have access to care. Well, what's interesting is, and it's actually now 40% growth in PCI centers, and we have a 1.8% increase in the population that can get covered. So was it really about access to care? Is ambulatory care center PCI about access to care, or is it about money? Is it about quality, or is it about money? I don't know. I will say that new programs and ambulatory care centers as well happen to go into places with more competition for market share. They happen to be in places with higher private insurance and higher state reimbursement for Medicare. And they're usually in states with weak or no regulation with wealthy, larger cities. So is this really about patients, or is it about the hospitals and the doctors? Now, an unintended consequence of 2,200 PCI programs in the country is, interesting enough, nobody knows how many interventionalists there are in the country. There are 6,500 boarded roughly. People think there may be as many as 10,000 people doing PCI, but the average operator volume is 33. Okay? And that does matter. I hate to tell you this. Think about it if you played golf. If you play golf 3 times a year, how good are you? If you play golf 100 times a year, how good are you? If you work with a swing coach once a week and work on specific drills and then play golf, how good are you? And this is a recurring theme of volume affects outcomes. So this is for PCI. I know nobody likes this. Nobody wants to argue it. The only people, of course, who want to argue it are the low volume operators or the societies, because they don't want to get rid of low volume operators because the societies make money off their membership and their attendance at meetings. It's about the economics. Now, this data that I'm showing with this around 100 number is true for cabbage, OB-GYN surgery, lap chole surgery, TAVR. All of the curves, the inflection of quality is between 75 and 125 of whatever it is a year. If you're doing less than that, you're likely in this bottom set of quartiles. I'm not trying to be mean. This is just the reality. And this is things we have to deal with. I mean, put it this way. If you needed a PCI, would you go to somebody who does 15 a year? Or would you go to somebody who does 150 a year? Would you have bypass surgery with someone who does 5 cabbages a year or somebody who does 150? Right? What would you do for you? Now, we updated this, and guess what? It didn't get any better. Almost half the people in the US do less than 50, which is the guidelines. The guidelines were dropped from 75 to 50 with not a shred of clinical evidence. Actually, the evidence says what they did was wrong. The reason they dropped it was because of structural intervention, that most of the famous operators went into structural, and because they were doing structural, their volumes for PCI dropped. And so the volumes dropped. They wanted to look good, so they changed the guidelines. Had nothing to do with outcomes. And again, guess what? Higher the operator volume, the lower your operator mortality, despite the fact that you're doing more complex, higher risk cases, because this isn't risk adjusted. And guess what? Low volume operators are more likely to work at low volume hospitals. That's like the last place they should work, right? Because the initial data from Seaport was high volume operators at low volume hospitals. Most of what they do is PCI for STEMI, but they did less overall STEMI than the other groups, which is sort of interesting when you think about the outcomes. Shockingly, less radial, which, as we talked about, STEMI is the one place where radial is most important. And because they don't do a lot, they're not very well trained, and they're not keeping up, they use a lot more contrast and a lot more radiation. And the same is true for CTOs. Guess what? If you do 50 CTOs a year, you're a lot better than somebody who does 10. Matter of fact, I don't have the slide on this, but the guys in Michigan just looked at their state reporting database, and it was interesting. If you go to an operator that does less than 10 CTOs a year and have them do your CTO, your success rate is 53%, and your complication rate is 3%. If you go to somebody who does more than 50 CTOs, your success rate is 84%, and your complication rate is 3%. So same complication rate, 30% difference in success. Which one would you go to if you knew? So hopefully I've been controversial enough. I've got everybody else steamed and angry. It's usually what happens. So I'll put out here, those who do will find a way. Those who don't will find excuses. So this is an adoption of technology cycle. There's innovators, early adopters, early majority, late majority, laggards. Where are you on this, right? Innovators tend to be younger, more recently trained. Laggards tend to be older. Don't be that person. You don't have to. It's a choice. You have a choice to be one of these things. And we can choose to be different, you know? And this always comes back to is ask the question, why? I tell all our fellows, ask me why I do what I do. If my answer is some form of because, then I don't know what the hell I'm talking about. But if I can talk to you about the physics, the technology, the engineering, the pharmacology, the history, the technical development, and explain how we got here, then you know what you're doing. Now, talking about data and what drives healthcare, I want to put this slide up, okay? So this is a slide of the next generation DES. It hasn't come out yet. So this is just early preliminary data, so I wanted to show it to people, but this is in a 2,000 patient study. So it's a fairly large study. So, the current, Synergy, Onyx, Zions, but this is the next one coming out. So I want to show it to you. So overall MACE, 37% reduction. CV mortality, it's almost statistically significant. It's 0.5% absolute difference. MI, 50%. TLR, 40%. TVR, 40%. Stent thrombosis. That's amazing, right? Isn't that exciting? How many people watching right now want that stent? How many people think, if you looked at the FAME-3 data, if we had that stent in FAME-3, PCI would have tied cabbage? How many people want this stent? How many people want their patients to have this stent? Okay. That stent is called IVUS. This is from a meta-analysis of image-guided stenting. In the United States, about 12 to 14% of patients get image-guided stenting. That's why the restenosis rate and outcomes are so poor. I don't know what it is at Texas Heart. My guess is it's 10 or 12%, at least hearing what your fellows are doing. So you want to make yourself have better outcomes with PCI? The simplest thing you can do is use an IVUS, which means you have to learn to use it. 70% of interventional cardiologists don't know how to interpret an IVUS. That's okay. You don't need to know. It's not okay to keep not knowing. There is about 12 billion resources to teach you how to do stent sizing and stent optimization with both IVUS and OCT. That's all you got to do. So if you want to have the 5th generation stent, you have it. Change your practice pattern. Learn to do image-guided stenting properly. We did it at the university. We went from 25% imaging to 93% imaging. You know what happened? Our stent diameters went up 0.5 millimeter. And if you think about what the cross-sectional area of is a 0.5 millimeter diameter, it's big. And that's why our restenosis rates went down 50%. All we did was change to image-based stuff. It's not huge. But we've known this data. There's 4 meta-analyses, 5 randomized trials. It's all over everywhere. 12% of people in the US do it. Why don't we change? And there's a lot of that. This is a little bit from a complications thing, but I want to focus on this upper left panel. So this is a human psychology issue, and it's for everybody in the room to think about it. And this is where it gets really hard because the mirror is being turned on you. So this is human nature. If I take a room full of people, it's a bell-shaped curve. There's a bottom quarter and a top quarter. And I think I've laid out that the bell-shaped curve of interventional cardiology is not like this and very narrow. It's very, very wide. Okay. And in that, you're going to have the bottom quarter, et cetera, et cetera. And then you're going to ask people what their perceived excellence is. So green is real, red is perceived. And I want you to notice that the people who struggle the most technically are the ones who have the highest opinion of their abilities and are the most afraid to have anybody watch what they do or coach them. And interesting enough, the people who are the best actually don't think they're that good. So you have to look in the mirror and go, where actually am I on this curve? And to do it, actually, you have to ask other people. And you have to ask other people probably who you don't want to ask because you don't want to hear the answer. And you have to be open to not wanting to hear the answer if you want to get better. And that leads you to this slide, the Dunning-Kruger effect. Again, this is just a human nature psychology. It's nothing to do with interventional cardiology. But people with the least amount of experience have the highest level of confidence that they can pull off what they're going to do. And then as they gain experience, they fall into the valley of despair, right? I'm doing harder cases. This is classic in PCI and CTOs. I'm doing harder CTOs. I'm having more complications. I'm doing harder CTOs. I'm having more complications. And what happens is most people hit the valley of despair and they quit because they can't take it anymore. I can't go see M&M. I can't deal with another complication. I can't deal with my administrator. Everybody's against me, so I can't learn. Unfortunately, you'll never get to be an expert because you quit at the point where you actually start to build your expertise. And this goes back to why are we so critical of people trying to learn new things? Why are we not supportive? Why are we not helpful? Why do we not want to develop? Why do we have to have our general cardiology colleagues get mad at the interventionalists? The interventionalists get mad at the surgeon. The surgeons get mad at the interventionalists. What? Who cares? All we want, remember, there's a person. We want that person to get better care. Let's stop getting mad at each other. Let's talk about how we each get better at our jobs, better at our craft, so that the next person can be treated. Because that's how cabbage developed. That's how heart transplant developed. That's how beta blockers developed. That's how PCI developed. It was people having the courage to fight back and build coalitions of people to support and elevate them. That should be the norm, not the rarity. And there is my boat, the Lioness, on its way to Alaska. And that is my happy place. And if I had the money to retire, you would never see me again because that's where I would be. So I'm going to go into a little bit about my passion, which is about complete revasc. So I started as a heart failure person. So I'm a physiologist by nature. So angina occurs when myocardial oxygen demand outstrips myocardial oxygen delivery. It's physics. It's simple, right? Could be high wall tension from AS. Could be a 50 millimeter, 50% FFR positive lesion. Could be a 90% focal lesion. Could be a 1 millimeter CTO. Could be a 100 millimeter CTO. It could be a 100 millimeter CTO with a vein graft to the PDA and the vein graft has a lesion in it. Could be any of those, right? Myocytes don't know. Only person who knows is you. You took the pictures. So when you send people to cabbage, or you send people to medical therapy for that matter, is it because they have ischemia? Or is it because of the anatomy? Or is it because of your ability or your perception of what can be done? Right? Because what I just said, the physiology is the same every time, right? You shouldn't cath someone who hasn't got an uncertain or appropriate indication for revasc because they don't have an indication. And if you are taking someone who's appropriate or uncertain, I will show you what happens. So this is data from Canada because we can't do it in the US because nobody tracks the disease. But what they looked at is people with either inappropriate, uncertain, or appropriate. This is now called rarely appropriate. And what they showed is their treatment. So now think about the people who wrote the appropriate use criteria. Are those the aggressive, we want to revasc everybody? Or is that a group of people who are pretty conservative? We got to make sure the data is right. We want to do it. I'd say they're the pretty conservative, right? If they say it's appropriate, man, this needs to get done. And what you see is a third of people with appropriate get no revasc. That's not an indications issue. That's a technique issue. Again, half cabbage, half PCI. Uncertain, almost 50% get no therapy. Now, we've worked a lot on this part, right? Which is if you're inappropriate, you shouldn't get PCI. And the reason is because if you do inappropriate PCI, you harm people. If they don't get fixed, when we put a stent in them, we hurt them. Now, interesting enough, the harm for the uncertain and the appropriate who do not receive revasc is equal. So why are people not up in arms about all these people with uncertain and appropriate indications for revasc not getting revascularization? Well, that one's easy to stop. Don't do that. This one's hard because it's about your ability, which means we need to hold people to higher competencies, higher standards. We need to rechange training. We need to retrain postgraduate training. We need to retrain our M&M and our colleagues to understand that as we learn, we're going to have complications. That's what happens. But that's a big deal. This is a huge number of patients being undertreated, not because they don't have an indication. It's because we tell them they can't be treated, which isn't true. And it has an effect. if you look at incomplete versus complete revasc, first of all, in the general population, we do a lousy job. And even in trials, rarely do we do complete revasc. It's about 55 to 60%. It's pretty bad. Now, does that have an effect? So this is from Acuity, not semi-trial, but this is called a paradox, which is the lower the syntax score, the less disease you have. So the higher the score, the more disease you have, the more opportunity you should have to lower that score to get better. But what actually happens is that patients have more disease. Interventionalists get worse at treating it because they don't have the skill set and the technique and the training to do it. So they treat less. So actually, the more disease you have and you see an interventionalist, the less likely you are to have that disease treated. And that has an effect. So first of all, most of it's what we'd expect: calcification, CTO, bifurcation, long, et cetera, et cetera. But it has an effect, which is if you leave it with a residual syntax score of 8, you do harm. Okay? That's mortality, 1 year mortality, versus if you make it less than 8. So your goal should always be to make the residual syntax score less 8. So when you fix something and leave the proximal RCA CTO, you're doing harm. You don't have to like it. You can get all upset. You can argue all you want. This is the data. Okay? So, and again, this is both surgical and percutaneous put together. So again, if you do complete revascularization, low residual syntax score, patients have a dramatically better outcome than if you don't, which is why the syntax trial, right? Syntax score less than 22, PCI wins. Syntax score over 22, surgery wins. That has nothing to do with stents better than bypasses. That has to do with the anatomy's harder, surgery wins. And the reason is surgery's easier because it's the same procedure every time. Open the chest, put on pump, sew on the grafts, sew the graft distal, take off pump, close them up. For PCI, well, I got to learn how to deal with calcium. I got to learn how to deal with stent, a long lesion. I got to learn how to read an IVUS. I got to learn how to deal with tortuosity. I got to learn how to do a CTO. And there's like 85 problems in CTOs to learn how to do it. I don't want to do that, so I'm just not going to do it. So surgeon's easy, I'll have them do it. But what if the surgeon can't do it? And again, this is just the last slide of complete revasc. This is from the New York database of populations. But first of all, realize only 31% of patients who got PCI got complete revasc. It's an indictment of the profession. It goes back to low volume operators. It goes back to institutions that don't image. It goes back to institutions that don't do atherectomy. It's about institutions that send CTO the right to cabbage and say there's a lesion in LAD without actually proving it with physiology. These are all the issues. So I hope I hear that Texas Heart and Houston Methodist is an awesome surgical program. So I hope there's a few surgeons watching, and I hope they're the guy in back laughing at us, because you should. We deserve it. But I'll also say surgery isn't better than stents. A surgeon is better than an interventionalist. And there are interventionalists who are better than surgeons. And that's what I think our goal as a profession is. Our minimum competency should move from that left-hand side where we're below the surgeon. We should want to move our competencies so we're equal. But that takes effort. And are we willing to take that effort? Now, ischemia came out a year ago, so I'm going to hit that real quick. And I'm going to hit it with a simple thing. I believe in ischemia reduction. I just spent an hour talking about ischemia reduction. So they asked for $100 million to prove that if you had moderate or severe ischemia on a stress test and you did revasc on that ischemia-causing lesion, patients would have a better outcome. That was the academic question they spent $100 million for. What'd they actually do? So again, stable patient, got a CTA, they were randomized either to invasive or conservative. Primary endpoints, everybody all knows this stuff. So first of all, 14% of the people enrolled in the trial had either no or mild ischemia. Well, if your trial's about moderate or more, we had enrollment issues because nobody believed it. So why are we doing a trial if nobody believes it from the start? Okay. And again, pretty typical population in your cath lab, 36% have no angina. So is that a typical patient population going to cabbage? Is 35% of the patients getting a cabbage have no symptoms? Interesting. But here's where it gets a little more interesting. Okay, so if you got medical therapy, basically 23%, a quarter of them got an intervention, either bypass surgery or a stent. So medical therapy fails 3/4 of the time or a quarter of the time, I guess. How does that affect my outcome? Because now I'm including these people in my 5-year outcomes who got treated. Well, that's different than if they got medical therapy, because now they're not being left on medicines. They actually had a treatment that reduces ischemia. Now, the one that I would point out, and this is really the point of these talks, is this. 20% got no revascularization, which means, and 2/3 of those who had an angiogram, so that's 15% of the population enrolled in this trial, did not have coronary disease. So imagine if I'm a heart failure doctor. I'm assuming there's some people here who do heart failure. And I'm going to do a heart failure trial of a new drug on heart failure reduced DF. Matter of fact, I think I did those trials. They were called the beta blocker trials, Merit-HF and the US Cardiologist trials. How would you interpret that data if I went to the Heart Failure Society meetings and said, okay, we used beta blockers in one population and placebo in the other population, and there was no treatment benefit because our event rates were lower. Oh, but 15% of the people in this trial had normal LV function. You would laugh me off the stage. I would never have made it to the stage. You wouldn't get published in Lancet. You'd get laughed out of a society. You can't include people without the disease in a trial. But in this trial, it was great. We put 15% of the population randomized didn't have the disease. Well, yeah, your event rates were low because you had 15% of the people don't actually have the problem. So I just, from a trialist standpoint, everything that comes out of ischemia from that point is garbage. They spent $100 million and they didn't do anything remotely what was their academic intent. Now, we could have another good conversation. 6% of the people who had disease that could not be treated with revascularization. So at Texas Heart, are 6% of the patients coming through your cath lab with coronary disease not able to get a PCI and not able to get cabbage? And if that's the case, can I suggest that both groups need to go back and do some work, because that shouldn't be the case. Now, again, the overall endpoint of the trial was neutral. Invasive at 5 years was starting to win. Like I said, imagine if you just took the people with the disease. Imagine if you looked at it as people who got revasc versus not revasc, what it might look like. And most of the endpoint was driven by paraprocedural MIs, which we already know have no long-term outcome. Matter of fact, spontaneous MI was reduced despite all of the garbage in the trial. So interesting. The other I would tell you is, if you have symptoms, revasc makes you feel better faster. If you don't have symptoms, revasc makes you feel better longer. So I think most people want to feel better. Thinking revasc still wins despite all the flaws in this thing. Now, this is the lioness. This would be my wife. And yes, that's the 2013 Boston. And yes, my wife, fortunately, is a very good runner. She finished 40 minutes before the bombs went off. My children and I were across the street from the second garbage can that exploded. Fortunately, because she's fast, we left and we weren't there. So sometimes life gives you opportunity that you may not realize. So I'm going to bring up Syntax 2 because I'm in my last few minutes here. This is how PCI should be done, okay? We do physiology of questionable lesions. We treat only lesions that are physiologically significant. When we treat them with image-guided PCI, so we optimize our stent result. And we do complete revascularization, which is we fix CTOs. Now, the first thing I want you to think about here is these people were randomized to bypass surgery or PCI. They were going to go for a cabbage. 1/3 of them, one of the lesions wasn't physiologically significant. So if you want to have fun with that, it means about 1/3 of people with LAD disease don't have physiologically significant LAD disease that you send for a lima. So I would suggest first and foremost, make sure that you're sending the person with actually a left main or LAD lesion that is actually physiologically significant, or you just wasted the best graft people could get. The other in this trial is they were much more aggressive about CTO and completeness of revascularization. And what it showed is, compared to the PCI of Syntax 1, they kicked the crap. So good PCI beat bad PCI. FAME 3, bad PCI, that would look like Syntax 1. Imagine if the outcomes were Syntax 2. And against a matched cabbage cohort, guess what? We finally tied. 25 years of PCI, we finally tied the surgeons. Woo, yes, we tied. It's not about cabbage. It's not about PCI. It's about doing your job well. And it's about the minimum competency to help your patients. So I'm going to leave you with some John Wooden quotes, which is, failure is never fatal, but failure to change can and might be. I'll ask all of you, if you don't have the time to do it right, I don't have the time to put the IVUS in. When will you have the time to do it over? Restenosis is a crappy disease to treat. And the last is failing to prepare, not training your fellows to do atherectomy, not training your fellows how to interpret an IVUS, not training your fellows how to do high-risk PCI. Failing to prepare is preparing to fail. So with that, I'll leave it. I think the care variability of the therapeutic procedures arises mostly from minimum competencies, and I don't think we do a very good job of holding our profession to any form of competency that I would think is fair for patients. I think, unfortunately, because of that, most procedural trials outcomes are affected by the operators, not by the academic construct they're trying to prove. I think that there's an inherent fear of complications that limit the technical growth and development of our profession. I mean, if you knew it was going to work, everybody would do it. People don't do it because they're afraid something bad's going to happen. That's how we say no. And to help try to overcome that, we're running a complications course. It's 2 days of nothing but interventional complications, and also about a third of the talks are on the psychology of how that affects you, because about a half of interventional cardiologists and a half of surgeons who have a bad complication have post-traumatic stress disorder for at least 6 months after that. And that will affect how they do their job. And we need to confront that, and we need to talk about that. I leave you with my email and my cell phone number. I'm happy to take any questions, and I'm happy to offer any help I can to help patients get treated and deal with complications over the phone so that we can help get better outcomes for people. Thank you very much for having me.
Thank you. Thank you, Bill, for an absolutely fascinating and amazing talk. A lot of people who may have tuned in maybe were expecting some sort of a CTO slide deck, and I'm just so pleased to see how you have presented this talk. Literally goes to the crux of how we are at crossroads of our own field, where we have matured with our techniques, technologies, but don't know what to do with it for the patient, who is the ultimate benefactor, should be the benefactor of this. So you kind of hit 2 points, nailed down 2 points. One is how do we believe data, which data to believe, and second is, if you do have data, how do we optimize the physician who's going to be able to make a decision for that patient based upon that data? So I do have a couple of questions, and we have some other questions. Hopefully we'll have time to get to. Data. You have made a very passionate speech about how data can be so misleading because how it's gathered. Medical therapy arm always suffers from crossover issues and compliance issues, and cabbage arm always deals with outcomes which are not accounted for, whether it's post-op CKDs and AFibs and on and on. And then obviously the PCI data sets have their own issues. So how do you go through this maze for somebody who is either is a referring cardiologist or non-invasive cardiologist or a new invasive cardiologist? How do you build a program? How you can tell a patient that this is the data and this is what I believe in?
Well, I think that the first piece when I talk to people is I don't talk about bypass surgery versus PCI. Matter of fact, I'm about to get on our cath conference, which has a heart failure transplant doc and our surgeons on. And effectively, if the surgeons want to do bypass, they get to do bypass. And if they don't want to do bypass, then I get to do it. And my job is, what were they going to graft? And I need to be able to fix that. And I think that the medical therapy discussion is a moot point. You know, why is it that when people cross over, that's not a failure of medical therapy? That is a failure of medical therapy. And so, to me, and again, the quality of life, I think, because 80% of what we do is about quality of life, trumps all of that. I mean, nobody talks about the mortality of hip replacement surgery, but at 30 days, it's 0.5%. It's the same as elective PCI, right? But where's the mortality benefit for hip replacements? There's no mortality benefit. It's about quality of life. So I think you have to be more open and honest. Is it your own personal faith? Well, I believe in medical therapy because I hate interventional cardiologists, and I don't like stent companies, and I don't like the money they make. Or is it, am I being objective about what really is being shown here? And am I being really honest? You know, I don't, when I get I get lots of people who don't want to have a bypass. I don't think I'm doing them harm by not giving them a bypass. But we talk about, here's the risks, here's the benefits, here's the downsides, here's the upsides. And a lot of them have already met a surgeon, and if they haven't, I always try to have the surgeon talk. You know, they can sell their snake oil, I can sell my snake oil. But I think that the key is, for all of these discussions to occur, they're only going to occur if you're open to learning the data. And most of the people who talk about this stuff have read the New York Times, or they read the abstract. So when I ask them why, they're going to give me the New York Times answer. Well, that's not a why. What I just tried to do is walk through the why. Here's all the pieces of where we are. And I think that's important for patients, and it's important for doctors to open themselves up to the why. And can you listen to that?
But then that also leads to possible wrongful suggestions by the providing physicians, because then the patient will end up getting what he or she, which physician they see first. So how do we...
That goes on every day.
Yeah. So then if RCTs, as your president, have their own flaws, yeah, why our societies are not putting more emphasis and believing on registries? Is that because we are not doing registries very well, or should we do a better job at real-world registries?
So I would tell you two things. The reason we have the NCDR, and we don't listen to it. I mean, the NCDR says if you're in a hospital that does less than 200 PCIs a year, you have worse outcomes. Did we close any of those hospitals? We have outcome data that says you do less than 50 PCIs a year from our registries. Do we mandate that people that do less than 50 get extra training, get extra management? And the issue isn't the data, it's how we react to the data. The challenge is the societies are like having the fox guard the henhouse, right? Societies are not about patients. Societies are about doctors, because that's how they get funded. It's about membership. I mean, what they want is more members. And to get more members, you don't go to the membership and say, we don't like you, get out. You say, oh, it's okay. We want to be inclusive, right? I mean, and that's the real challenge in this is, until we legislate competency, until we, as a profession, want to hold ourselves to a higher standard, everybody's input, hospitals don't want higher competencies because they want low volume operators so they can keep their PCI programs, because they get paid whether it's good or bad. And doctors, we just want to be able to do whatever we want to do. We don't want people telling us what we can't do. And the societies want for money. So, that's the real challenge, is it's how do you change the economic to be about patients rather than about doctors, hospitals, and societies. And I think that's a way outside of the scope of this talk, but that's really the controversial part that you have to get to. And that's what I'm trying to get our societies. If we want to talk about money, great, we can talk about money, but then don't talk about patient care, because they're diametrically opposed for the most part.
This leads to another question about standardization of skill sets. I guess this is about PCI operators. How do you standardize PCI operators? I guess it goes to your original talk about how it is difficult to regulate that, isn't it?
Yeah, well, I mean, again, the fox guarding the hen out. We're not going to regulate it. If you're asking me what I would do, the first thing I would do is, so they're about to change the fellowship guidelines for ACHME. Sky is writing a new document, and they're going to dumb it down. They're going to reduce the number of PCIs and reduce the number of things that you need to know to come out into our profession. I think that's wrong. I think that what we ought to say is, okay, what are the appropriate skill sets for an interventional cardiologist? You need to know ultrasound-guided fluoroscopic access for femoral, large bore access for hemodynamic support. You need to know how to do radial so that you can do STEMI and have radial access to reduce complications. You need to know how to do atherectomy, all the forms of atherectomy, so that you can do what the patient needs. You need to know how to interpret an imaging catheter, either IVUS or OCT, for sizing calcium and determination. Probably need to know how to use a guide extension properly. Probably should know some basic antegrade reentry stuff with Stingray, right? And then what you do is you make those set of, these are the technical skills people need to learn. Then you go to industry and you look at every fellowship program and you see how many atherectomy caths, how many imaging catheters are being sold at their sites, and you take every site who doesn't meet the number and get rid of them, and you get rid of a bunch of fellowships. And yes, you'll have less fellows, but they'll be better trained. Or you will scare the training programs into the faculty who have not learned these skill sets into learning these skill sets to ensure that they then train our fellows. That would be my first place. The second piece that I would do, because it's the only thing that I can figure out to make economics work, is to maintain an accredited echo lab, which means reimbursement. Everyone who reads has to read 300 echoes every 2 years and has to have 30 hours of echo-specific CME every 2 years. Mandated. So every accredited lab, and I know there's general cardiologists still hopefully on, they have to do that every 2 years to read an echo. To do interventional cardiology, 0 and 0. Which is more dangerous, reading an echo or doing PCI? So why don't we just legislate and say all the interventionalists in the United States, if you want to keep your certificate of need at a hospital, every 2 years, they have to document they've done at least, we'll say 100 procedures. That's the guidelines, 50 per year. So every 2 years, they have to document they've done 100 PCIs, and they have to document that they have 30 hours of interventional specific CME. And I think at least 10 hours of that should be on complication management. So that way we know everybody is current. Everybody's been to training. Everybody knows what's going on so that we can't have these gaps in care. That's what I would do.
Great. Maybe we have time for one last question. We have a few more left, but I'll...
you can email me if you'd like. I'm happy to take them.
Well, yeah, guys, please make a note of his email address, which is on the last slide of his presentation. Any benefit of PCI to asymptomatic CTO patients? I guess that maybe you can help us, maybe part of the complete revascularization talk. How do you approach patients who have LAD ischemia, but also as an RCA CTO?
Yeah, sure. So I'll put it in a couple ways. So first of all, if you look at co-localization of ischemia, the patient you just described is more likely to have infrawall ischemia than antiwall ischemia. So you've already proven the ischemia. So when you fix the LAD, I'd argue, what the LAD do for the patient? But let's think about this a little bit differently. So why should we treat an asymptomatic patient? It's ischemic burden. If you have a sum difference score over 8, more than 10% of the mask, should get treated. But 80% of the CTOs I treat are symptomatic. The other is, if you look at care variability on angina evaluation, that wide, super wide bell-shaped curve is the same. Most doctors, if they know the anatomy, will change the patient's symptoms because nobody gives people SACs. And actually, most people with SACs actually still have symptoms. So the scenario you bring up is actually much rarer than you believe. Most people with CTOs have fatigue and shortness of breath. If you read the ACC board review, that's the first two symptoms of angina. And they have it because of that. So they actually are symptomatic. So if they're truly asymptomatic, and this would be true for not just a CTO, it's any lesion I wanted to treat, because just because I can treat it doesn't mean it's the right thing to do. I believe in physiology. So if you're completely asymptomatic, then I look either for a sum difference score of greater than 8 or 10% of the LV mass that's ischemic, because that data is pretty good that you're now providing a mortality benefit. The last piece I would say to that, though, is for everybody who tells me we shouldn't be treating CTOs, I'll argue this. In every surgical registry in the United States and Europe, the number one reason on meta-analysis, not left main, not three vessel disease, not diabetes, not LVF, it's the presence of a CTO is what sends you for a cabbage. So if we don't believe CTOs should be treated, why is that the case? It's unconscious bias.
And that's a very compelling point you just made. So thank you so much, Dr. Lombardi, for being here with us today and sharing all your wisdom, your knowledge, and this very great overview of where our field is today with us at Houston Methodist Hospital. Thank you so much.
Thank you for having me. Enjoy.
Thank you.